Yeah, okay. So I'm Sarah, one of the registrars, and I'm just going to give a little fun little ECG quiz for today. This is just going to be a collection of ECGs that I've come across that I've found interesting or tricky. It was supposed to be in a quiz format, but it didn't quite work out, so we're just going to use show of hands and maybe some audience volunteers to go through these. And the main question is going to be generally, does this patient need urgent reperfusion or not? So we'll get started with the first ECG. You've just got a 45-year-old male with chest pain, and I'll just give you guys a bit of time to have a look. Just hands up if you think he needs urgent reperfusion, or if you don't think so, the other options would just be, you know, your serial assessment, monitoring, other options.
Just to confirm, is the game like would you activate the lab?
Activate the lab or activate reperfusion protocols. So we'll go hands up for yes. Hands up for no. Okay. What's that?
I can tell it's going to
All right. So this patient has an isolated posterior STEMI. Usually rare to see in isolation, more so in the context of a big extension of an inferior or lateral infarct. Generally what you see is what you're actually looking at is the reciprocal changes because you're looking anteriorly at the posterior part of the heart. So those horizontal ST depression with upright T waves, four broad R waves, the dominant R wave in V2. And we would confirm this diagnosis using leads V7 to 9. And this is a subtle change, so you only need 0.5 millimetre of ST elevation to make this diagnosis. That's just an illustration of where you would put the leads if you were doing this, so just along the back under the scapula on the right side. And this is a bit of an explanation of why you're seeing these changes. So if you look at the top trace, that's what we're seeing, which is looking anteriorly at the posterior part of the heart. But if you put the leads on the back and look at that sort of reflection, then it's quite obvious, and that's what you should see if you do the 6, 7, 8, and 9. Anyone have any questions about that? Yeah. Don't ask me why.
It's going to be 7, 8, 9 posterior.
Yeah, so if you're going to put them along the back like that, I probably should have added an ECG with the elevation in 7, 8, and 9, but that's what it should look like, and that sort of explains why you get the big R wave, which really what you're looking at is a Q wave, and then that flat ST segment depression with the upright T wave, which is sort of T wave inversion the other way. Okay, that all good? Next ECG. Give a bit of time to have a look. Okay, hands up if we're activating cath lab. Hands up if we're not. Okay. Okay, so what we're looking at, does anyone want to have a go at what we're looking at?
So I'm just looking at, so we've got a paced left bundle morphology. So it might be appropriate to use our modified composite criteria here. 6 and less so V5 stand out today. And V1.
So got a paced left bundle morphology, so we should think about the modified composite criteria. V6 being inappropriately concordant, and lead 1 is also inappropriately concordant. I don't think the ST elevation is excessive, but it's 25% or more. I think that's probably pushing it of the preceding S wave. Open to ideas, but I probably would.
ABL is
looks a bit weird, doesn't it? But it is, I guess. But yeah, I think I probably would activate based on that. Any other takers?
Good. Yeah. So I mean, I didn't use calipers, sorry, for the presentation to measure, but I think, so what we're talking about is the new modified Scarbosa criteria, which is slightly more simple than the previous criteria. So when we've got a paced rhythm or a left bundle, it can be quite hard to differentiate a Stemi from just a normal paced rhythm or a left bundle ventricular sort of pattern. So what we're looking for, so does everyone understand concordant and discordant ST elevation and depression? Basically, we're just looking for the T waves and the QRS and the elevation or the depression to go in the same direction. So we're looking for more than 1 millimetre of elevation, and then we're happy that that is going to lead us to reperfusion. Any concordant depression in V1 to V3 of more than 1 millimetre, and what we call proportionally excessive discordant ST elevation, which is defined as 25% of the preceding S wave. So I think in V2 and V3, it sort of looks like more than 25% to me. If you just even count the big boxes, it's kind of 3 big boxes down and 1 big box up. There's a very medical technical terminology there. So that patient would be considered to have a Stemi and be appropriate for cath lab activation. Any questions about that? That's just another example. So in this case, just applying what we just talked about, are we going to activate the cath lab for this 68-year-old male who presents with chest pain, shortness of breath, diaphoretic, with some APO on clinical examination?
You were nodding?
So I think there's like concordant elevation in the left leads.
So 1 and AVL, I think, are Scarbosa positive.
Yeah, so they've got so I would call that discordant because we've got the QRS going up and then the ST depression. Does that make sense? Yeah. Yeah. So in this case, I think this was just a left bundle. Does everyone agree or anyone disagree? But then this is that patient's ECG 30 minutes later. Any thoughts about that one?
Multiple leads with concordant ST depression in a millimetre, which is one of the criteria of.
Yeah, say it again. So Scott's just said that there is now concordant ST depression in multiple leads from V2 to V5. So that then would be sort of fit criteria for urgent reperfusion. This patient actually ended up having, so they were in cardiogenic shock with APO at the time that they presented. It was nighttime at Canterbury Hospital, bit of difficulty convincing the cardiology registrar on the end of the phone to take this patient, and they ended up staying in Canterbury till the morning with an echo that showed apical hypokinesis and a fairly normal cath. So that was I guess a Stemi mimic, but still would be considered criteria for considering reperfusion. Okay, next one.
I'll have a go. So she's got what looks like an incomplete left bundle branch block with hyperacute T waves in V3. So the T waves taller than the preceding QRS. So the combination of those two plus chest pain would mean, yes, that's a STEMI equivalent.
Yeah.
If that left bundle's new.
Yeah. Any other thoughts on this bit of a funny looking ECG? Yeah. So, yeah, I agree. You sort of do have that pattern of peak T waves with possibly some ST depression in V2 and V3. And yeah, with possibly some intraventricular conduction abnormality. This was actually, I'm going to single you out here, Chloe. This was Chloe's patient in the middle of the night when we were first junior registers together, and I was the ICU registrar at Concord, and Chloe was the ED registrar in charge at Canterbury.
Yeah, first 7 nights, she was a lady with a very high health literacy who came in saying, I can't breathe and my chest has got dull pain radiating to my left arm.
Yeah, and we checked her blood gas and her potassium.
No, blood gas didn't come back because it was Canterbury, the machine had broken, and I had never thrombolyzed someone, having only worked at a cath lab place. Anyway, do you have the next one? And that's what happened as she became peri-arrest.
In the first one, I think I took a good example of the winter T waves.
Yeah.
So they're like tall T waves with upsloping ST depression with Victoria leaves.
Yeah,
Can I give you the final kicker for this one though? Normal creatinine with a potassium of 9.4, and about 4 days later in ICU, because I couldn't explain why the potassium was so high with normal creatinine, the very clever tox registrar did an abdo X-ray and found the bezoa of slow K tablets.
So I think that on an overtime shift, the patient pulled an intern aside and said, I've got something to tell you. Actually took, I think it was 100 potassium tablets.
Yeah, it was like 2 or 3 bottles or something.
But yeah, I agree. Like this, you know, if you're on a night shift at Canterbury and you get an ECG like this with no story, no blood gas and no story, this would be quite a tricky one. And that's what it looks like as it progresses. And just a little reminder, ECG changes in hyperkalemia. So we get peak T waves, big wide, and then flat P waves, and just pretty much all kinds of arrhythmias and blocks and just bizarre looking ECGs. And that's a nice little just illustration of how to think about hypo versus hyperkalemia there. Any questions about that one?
I like the description that the T wave would be uncomfortable to sit on.
I like that. Yeah, and then, you know, if anyone is a fan of the ECG Weekly, a mum or two, he just, you know, anything that looks bizarre and unexplainable, just always think about potassium. Okay, next one. What do you expect the echo to show? Angus, you've got the mic and you look like
yeah,
you're
someone
thinking.
just handed me the mic. Just not intentional. The thing that jumps out here to me is the massive R wave S wave. The upright R wave in V1. Just very unusual. That doesn't look good. Yeah, it's huge. Yeah, I would just be echoing this patient. And that would be how I'd be making my diagnosis.
Got a hand up at the back. Yeah, so it's been suggested that there's an S1, Q3, T3. Do you want to? Yeah, so this patient has a right bundle, some evidence of right ventricular strain with the sort of ST depression in the precordial leads, and looks a bit funny as well in the inferior leads, with the typical S1, Q3, T3. So this is suggestive of a PE, and that was what they would have found on an echo. Any questions about that? Does anyone want me to explain it further? And then this is just a reminder that the S1Q3T3 is not sensitive or specific for PE, so it's something interesting to look for. But the most common thing you'll find is this non-specific ST T-wave changes, which is usually suggestive of right ventricular strain, sinus tachycardia, RV strain, right bundle, right axis, dominant R wave in V1, and then just some other sort of atrial arrhythmias. And they say simultaneous T-wave inversion in, I think it's mostly V1 and lead 3, but in inferior and right precordial leads is the most specific finding in fever, according to a study.
So if you go back to the previous one, that's they're not particularly tachycardic, and I suppose, as with most findings in medicine, you say the sensitivity is only 44% for sinus tachy, and that probably really depends on what their inclusion criteria are. If they're looking at shocked, horrible patients with PE versus just anyone who had a intermediate or higher VQ when they ever did the study.
Yeah, that's a good point. Okay. So this is just, a 55-year-old who's had an ECG immediately post-ROSC. I guess you can pass your mic on if you want. Yeah.
I might look at V1.
Yeah.
Which I think is asking V1 worries me on this person. It looks like a junctional rhythm, can't see P waves, but the ST elevation is massive in V1, which raises the idea of a proximal LAD, which would explain arrest in a 55-year-old.
Yeah, agree. So, ST elevation, you can see it's quite massive in AVR, V1, V2, and there is a fair bit of reciprocal depression, and there's an arrhythmia. The reason I included this one, because it does look fairly obvious, is that I was just watching my ECG weekly and came across this resuscitation journal that was talking about the timing. So I don't know that there's really any strong evidence or opinion, and maybe some of the clinicians in the room can speak to this, but about the timing of basing your findings on activating the cath lab. So this was sort of a cohort study that showed that if you did the ECG immediately after ROSC, it had a high rate of false positive ST elevation ECGs, thought to be just from the downtime and the shocks and the adrenaline that these people are getting. They only took patients who had ECGs before cath lab. So again, I'm not sure exactly the exact significance, but it was just interesting that they've said that they recommend waiting 8 to 33 minutes after ROSC to repeat your ECG, which I guess if you've got a patient in the resus bay in the middle of the day in a cardiac centre and you've got an ECG like that, what are you going to do? But just thought it was an interesting article. Any opinions on that?
It's an interesting question, isn't it? Because you get ROSC, like quick, let's do an ECG and find, no, we've got to wait 10 minutes.
Yeah, exactly. Exactly.
And you're like, well, should we have something?
Yeah.
I guess it does raise the importance of serial ECGs in these patients. Most of these pathologies evolve over time. And it's going to be very rare that you're going to be not continuing to work on that patient for another 10 minutes. So if you do your immediate post-ROSC ECG and you make an early referral to cardiology and you do another ECG during that referral, probably grease those wheels a little bit.
Yeah.
One of ECGs,
Exactly. And that's this patient's ECG, let's say 10 minutes later. Looking much better. Then that's just the little bit of a summary of the study, if anyone was interested. Basically, they were just looking for false positive ECG findings, so patients that had Stemi criteria but didn't have anything on the cath that was worth
That's still
presenting.
pretty compelling reason to go to the lab if 82% of
Yeah.
the skills going to show something.
Yeah. So I wouldn't say don't activate, but it's just something to think about, that it can just be the findings of the arrest on the ECG.
Sorry.
Yeah.
I sort of wonder how many of these patients might have stun myocardium or tachypseudo, like who need to go to the cath lab anyway.
Exactly.
Have a cath negative diagnosis. So,
The question is, does it need happen now?
Yeah.
This is just the inevitable push between cardiologists and they don't want to take cardiac arrest patients to cath lab and spent the last 50 years trying to prove that no one actually needs cath. And we all want them to go to cath because we want the problem to fix. And
you call them and they say, can you call me back in 8 minutes, please? And
I think we have the opposite problem where I work. Cardiology will take anyone to cath at any time. And I think we send way too many patients straight to cath without actually stopping and thinking and scanning. And I think in the near future it won't be an issue, because unless there's a bund or Stemi on the ECG, we'll be doing an urgent CTCA. There's the technology's there now to do that in real time with high sensitivity for coronary regions. So if you've got a clear coronary angio on CTCA, they won't be cath lab, not straight away.
Wow. Okay, yeah. So I guess more something to think about than to take super literally. Okay, whoops, I sort of left all the answers on this, but anyone want to have a go?
So it looks like we've got some anterior septal, well, really just an isolated V2 ST elevation that looks like some reciprocal inferior depression in lead 3, a little bit of an AVF, and I can see AVL is also raised as well. So probably some kind of LAD occlusion, some inferior reciprocal change.
Yeah, so this, agree. And are you activating the cath lab?
Well, it's tricky because they're 23-year-old male. So, you know, what's the pathophys of this? Is it unlikely to be thromboembolic unless we know anything about their past medical history? Is it vasospasm related? Is it, it depends on the presentation, the context.
What was that?
Strenuous parting.
So, and what are your other options if you're not going to go crazy and immediately activate cath lab for this patient?
I think you can try and provide some coronary vasodilation. You can try and decrease myocardial wall oxygen demand through various pharmacological mechanisms, i.e., not pull the trigger on an angio straight away. Do an echo, find out biochemical markers.
So I guess you're going to sort of also judge it on, you're right, like the patient, their clinical story, how do they look, what do we know about their background? Is that a hand up? No.
Chris has some forensic suggestions anyway.
And you might do some serial ECGs and find that there's not really any changes. This is a good sort of Stemi mimic where you can see you've got ST elevation with reciprocal changes, you've got Q waves, you've got poor R wave progression, but this patient has LVH, so just with the left ventricular strain pattern. You can, I guess with this case, what they did was the serial ECGs and the serial assessment, and the patient didn't really seem to fit the ECG, and did an echo and found out that they had big left ventricle. I won't go into the details, but it's just a little revision of LVH criteria. Okay. Any questions about that one?
You'd been nervous though, wouldn't you? I think an echo is key.
Definitely. I mean, that's I guess the point is that all of these are ones that make you think probably a STEMI and then it turns out to be something else, or vice versa. But yeah, definitely not saying to dismiss it or anything, but yeah, you want to assess and get some further information and speak to cardiology and all of those things. Okay, so this one is a 30-year-old female with chest pain and diaphoresis. You don't have any clinical history, so thinking about what it could be.
Those 30-year-olds should have that ECG. 900-year-old.
Sodium channel blockade or some sort of Cox ECG?
Someone want to describe what they see on the ECG?
Huge light.
Yeah.
Yeah, I'm thinking in that demographic, chest pain.
Yeah, in that demographic, thinking tox or something like that, but chest pain is not a classic presenting symptom. But I'm concerned about sodium channel blockade with the QRS that wide.
Yeah, so it looks like a really broad complex ECG. But if you look at leads V3 and V4, what do you see there?
Yeah, so there's ST depression in V3. I'm not as convinced I can see that in V4.
Yeah, so I guess V3 and 4 look more like sort of narrow complexes with ST changes. So this patient actually has a massive STEMI, but it just, because of the way the whole ECG looks, it looks like a broad complex. So I think it'd be really easy in ED to see a 30-year-old female with an ECG like that, and that's what I would do, go straight to tox and electrolytes and things. But I guess the sort of learning point in this ECG is to look at every complex quite closely. And I mean, as you said, chest pain and diaphoresis doesn't necessarily fit with a 30-year-old, so you're going to be investigating and doing serial ECGs and things. But that was a really interesting case. This patient went to the cath lab and ended up having a big LAD occlusion. And that's just another example. So this is another patient who had a cardiac arrest, who got ROSC and had an ECG like this, like 9.5 minutes, I think. And it does just look like a big sort of broad complex tachycardia. But if you look at, I don't actually know, that's V3, you can see that there is that sort of one narrow complex that gives it away. Okay, a few more to go. So what's this? Spot diagnosis patient. Yeah. So are we activating the cath lab for this guy?
Yes.
Pain now.
Yeah.
Excellent question. He's pain-free now. Good. So, yeah, I'll go into it in a second. What about this one?
It's uncomfortable.
Anyone just want to yell out the diagnosis?
Just De Winters.
Good. I know we activated the cath lab for De Winters.
Yes.
Yeah, good. Okay, so this is actually from the PAXA guidelines that we use in New South Wales. So you can see there that the STEMI criteria include the De Winter T waves, and that's quite straightforward. So what you get is tall, prominent, symmetrical T waves in precordial leads with upsloping ST depression. And then this is basically a STEMI equivalent. And you can get that before or after you see the T wave, the De Winter T wave pattern. And it's seen in 2% of acute LAD occlusions. Whereas Helens, sorry, there's lots of writing on that slide. I'll just try and explain it better. But really, it can be, what happens is you get a sudden complete LED occlusion with transient changes, which you might not actually catch on ECG while the patient has pain, and they will get this sort of reperfusion ECG. But they are at very high risk of going on to have an MI within the next few days to weeks. So you don't necessarily need to go immediately to cath lab unless the patient has ongoing ischemic symptoms or has the pseudo-normalization of T wave. So if they go from a Helens pattern then to an upright T wave, then that would be an indication for activating cath lab. Does that make sense? Did I explain that properly? Yeah. Okay. Any questions about that? Okay. Oh yeah. So then that's just a little bit of revision. So Stemi equivalents are left bundle with an unstable patient or modified scabosa, the posterior infarction with the depression in V2 and V3 and the De Winter T waves. And then the Stemi mimics where you're not necessarily going to activate the cath lab straight away would be Helens Brugada, and they also include pericarditis in the National Heart Foundation guidelines. So things that you do need to refer to cardiology urgently, but don't necessarily need to activate cath lab urgently. Spot diagnosis. Yeah, so this was a patient who presented to RPA who missed their dialysis, who was sat in a chair because there were no monitored beds available. Renal were consulted and they just took him straight to dialysis without any monitoring, and he did well. Okay, what are we doing about this patient?
That's on a bumpy road between.
Yeah, and what are the other options in a stable patient, if you can be stable with that rhythm? Yeah, you're going to shock them, but that.
Sort their K out, sort their mag out. Maybe now speak to cardio about what they want to use for it, amio or whatever. Yeah,
what won't you give them? What won't you give them? Yeah, exactly. So this is the patient's ECG after they were shocked. So anyone want to, Angus, you've got the mic.
So it's not quite tacky, left axis, short PR interval with delta waves in the precordial leads. Suspicions for WPW.
Yeah, and then just for anyone who needs a little reminder, so the Wolff Parkinson White with AF is usually very, very tachycardic, with wide QRS complexes that vary beat to beat. So that's sort of two things that can set it apart from VT. And if you give them AV node blocking drugs, you can block out their only normal conduction and just send them into a loop of aberrant conduction and cardiac arrest. So that's one to look out for. This ECG was given to me from a friend, so I'll get some expert advice because it's a bit tricky to me, but yeah, anyone got any thoughts on what's happening here? Now that I've tricked you with all the previous ECGs.
So given her age, so I guess it's a broad complex regular tachycardia, and given her age, you'd be less inclined to think about VT, you'd go for SVT. But I guess looking at some of the features, so she's got that kind of taller left rabbit ear in V4 than the right, and is that Josephine sign? That kind of little nadir on the down slope as well. But then I guess sorry, Josephine sign. So you get little nadir in the downsloping segment before. So looking in V4, for example, can you just demonstrate, Sarah?
Yeah,
So there, that little notch, which is normally quite specific for VT. But then I guess you'd also look for like fusion beats and capture beats, which there don't seem to be. So yeah, I'd find it confusing because on the one hand, I'd be like, oh, there's a couple of features of VT there, but why would you have VT?
Yeah.
The treatment wouldn't necessarily change if her systolic 60.
Yeah, exactly.
Yeah.
Have we got the right person's ECG? Patient in front of you is 26.
Yeah, that is a really good point. So yeah, this is not the right patient, which is why I guess why I was so confused. Yeah, someone sent this to me and it didn't really fit. But yeah, I think this is VT, and I think if you find one or two features that make you think of VT, then and if the patient's unstable, you're going to treat them as VT. Yeah, so let's ignore the combination of these because I've obviously just put the wrong ECG in. Let's just say you did have a young girl with a broad complex tachycardia, and then this was the ECG post-cardio version. Can anyone see anything on that might explain why they've had a broad complex tachycardia?
So is that an epsilon wave?
Yeah.
In V2 and V3? But that's suggestive of homogenic microventricular dysplasia.
Yeah, exactly.
So quite lucky to have caught her because they often present in sudden cardiac death. So they'd absolutely need to be admitted. They'd have a cardiac MRI. They'd have a pacemaker. They'd have genetic testing.
Yeah, exactly right. And when they do go into VT, they generally will tend to have a left bundle morphology, which is why that other ECG confused me, but now it makes sense that it wasn't related. So if you do see a young person with a ventricular tachycardia with a left bundle morphology, that's something to think about. Everyone happy with ARVD? Cool, I think. Yeah, and then so basically, if you get any of them that have, if you just find them just with that ECG, you can manage them with beta blockers and warfarin. But if you find them with the arrhythmia or the syncope or any high risk features, then yeah, they need to be urgently admitted and managed. That's just another example of a clear epsilon wave there. And then this is the last ECG. This was a Bankstown patient who presented with COVID, with shortness of breath and chest pain, and this is the ECG that you find. What's that?
Looks to me like they have left bundle, which may or may not be new, but AVL looks like there's ST elevation there, so I'd be concerned for an LAD or LMTA.
Yeah, and what else might you think of in this COVID patient?
I mean, PE, but given it doesn't fit with anything except the tachycardia, myocarditis is the other thing.
Yeah, exactly. So these are tricky ones, I guess, to discuss with cardiology again, because they're sick and unwell, and then they've got these changes. And this actually was a dynamic change. So the first ECG was okay, and then it progressed to this. And I think there was a lot of back and forth with cardiology, and there was a bedside echo, and the patient ended up not going to cath lab and going to ICU with a presumed myocarditis diagnosis. They did go to cath lab a week or two later and just had a very small osteal lesion. But anyway, that's an interesting one where it does really look like it meets sort of cath lab activation. It is tachycardic, but still with the elevation and the reciprocal changes and the decision not to go to cath lab because there's probably another diagnosis I think she did have elevated trops, but probably nothing too impressive on the first one. Any comments about that case, or like what other people would think in that scenario? Chloe's giving me a thumbs up. Yeah. Okay. That was my last ECG. That's just a little reminder of to the territories and all that. And then any questions?
We should have Alex.
Okay.
Hey, you're coming with me. I ain't singing this shit by myself. Okay.
Are we doing?
Making some squares down there. Put the stretcher together and I'll lay out the sleeping bag. You know the one that's on the back of 63? Yeah, it's still out there. Yeah, pretty much. Yeah. You need a good acronym for a study, don't you? So we came up with one. Yeah, that's it. This is Helens Supply. So very quickly, there's a couple. Sorry?
Not very quickly, stretch it out.
Stretch it out, right. There's a couple of videos in this that have patients that have not given consent. How does that work? Can I do that? Yeah, as long as people don't share it. Right, so anyone here don't share it. Don't take photos, don't share it. The idea is this is a project that's been running for some time, and what we're looking at is the use of the ventilator whilst on the winch to manage our intubated patients. So we're looking at stretcher patients that are intubated in remote and austere locations. Fortunately enough, that happens to be the title of the project. So, and the idea is that this is not just for helicopters and winching, but that the principles and the process will be a nice foundation for all of the CCPs, particularly because we tend to be the constant throughout the organisation. And largely this sort of logistical management of the scene and the resources and coordinating that process of extrication has to fall to our group. Obviously with the hand of the physician and that real medical team model that we all work towards. So with that in mind, this is to say that the project itself is for obviously to include Orange and obviously to include the road CCP colleagues, because there are a lot of cases where we're coming off ships at sea, we're coming out of industrial work sites, we're coming out of places that are considered austere or remote in terms of their relationship to other facilities and other resources. So the back of the ambulance, I'm not going to call remote or austere, but if you happen to find yourself at Orange and you're doing a job and the patient's gone over an embankment down near Safala and they're proper crook, the extrication phase is going to be via a stretcher of some description, probably a Stokes type picture. Yeah? And so managing that patient movement, which is the riskiest part of once we've done our clinical meaningful interventions and essentially sort backs and control, and we're starting to manage the part of the problem that is the patient's location as part of their pathology. So part of why they're sick and is to do with where they are. And so that's what we're looking at fixing. So there's a couple of videos in here. We're going to go through what this cyclic will be about. So everyone attending cycling will go through essentially a patient packaging session. If you are winch trained, you'll be doing that in relation to some winching stuff. And if you're not, then I want you to think about how you would incorporate that into your current workflow for those patients where you and your colleagues find yourselves in remote or austere places, because that would fit very nicely with the project. Part of this is born out of a bunch of cases I did earlier on in my time, and I found that often you were trying to problem solve or troubleshoot in an already complex or demanding scene. And so because we have a really good system of essentially working the problem before it's a problem, as in running sims and pre-arming and pre-loading our teams so that they have a solution before they're faced with the problem. And I found there was a gap for me. And part of it was that there seemed like this really handy bit of kit that could ventilate a patient, and we use it all the time, called a ventilator, and we don't use it when we're on the winch hook. And part of that's a legacy piece, right? So early on, we had some issues where the BVM was squashed shut by the downdraft of the aircraft. And so that led to a change in the system, which meant that we used a bag that had a stiffer or more rigid, self-expanding nature. Does that make sense? And then that was a change. Then we also didn't have a ventilator for a long time that we could really use in this space. And 4 years ago, roughly, we switched to using the Megamat Standard 2, which was superior to the Standard 1, and probably cost twice as much. That's why Wyman are doing really well. And essentially, we came up with an Oxy Sock 2, which was a way of delivering the ventilator and the oxygen supply on the winch hook to a scene. But as I said before, we certainly use this in our road vehicles, and we certainly use it in Orange as well as non-winch bases. So that's sort of where the need came from, right? So I identified that there was a need. We developed a new Oxy Sock. You can see the old one, I think, behind me there. Yeah, that is the old one. So this is quite a few years old now, this image. You got?
I just wondered what the white thing around your neck was.
I know that's a trigger for you, Cliff, but I respect you, but you and I disagree on that. Respectfully. And I give my consent for this photo. This was a patient that was being intubated in a remote location, and at the time we didn't have a ventilator that we could use in that space. There was a Zoll monitor you can see in the sort of bottom left picture of the screen, and we still actually don't have a great system for monitoring these patients in those remote locations. We've got this massive big monitor defib that does 1,000 things, when really all we want is arguably ECG, NIBV, SATs, and CO2. So, we get some more funding, maybe we get a monitor that allowed us to do that. And they're out there. But certainly the point of all this is that you've got a patient there that needed extrication, and the only way out was via winch. And so to paint a bit of a picture, I'm going to play a quick video of what that looked like. And go. Oh, you don't get sound. Oh, it sounds like a helicopter. Oh, right. So it just sounds like a helicopter. Really, not going to add a lot of value. Besides, then I can talk through it. So basically, you've got the aircraft coming in, and what you can see on the screen there is the physician. So that big slab is sort of where our extrication point is. The slab pickup, the patient is at the base of that slab slope, and the doctor is ventilating with a hand BVM. Now, there's multiple times throughout this evolution where the doctor needs to go, or the stretcher attendant needs to go hands off. And part of that's the hookup, and so you'll see me do the actual connection. And that's a risk because we're introducing something that's not, you know, our most common method is that the person connecting to the hook is the person doing the actual hookup itself. And so we should be really trying to, you know, work that into every situation. And so we have the equipment, we have the means, we just don't yet currently have the policy and the process to support that. So with this in mind, we ran a simulation where we looked at using the ventilator. It was blinded, and it was a few years ago now. I'll just let this play out. Essentially there, I'm doing the chops, I'm doing the hookup, you know, and there are multiple periods where you're essentially going hands off the ventilator and you're stabilising the stretcher. And that's going to be part and parcel of that process. But we have a better way of doing it, and that's to use the ventilator. It also does great things like if we run through this training package now, which I'm going to give to you, then you've got a nice systematic format that you can follow and you can use then to help give you a bit more bandwidth and a bit more, you know, essay with these cases that, you know, truly are the sort of unicorn cases. We only do around 12 of these as an organisation every year, with 8 of them being done out of Sydney and the other 4 being done throughout the other bases, most of them at Wollongong. And so they're a true halo procedure. There. I'm actually holding the tagline, so I'm actually drawing. It's my caveat. But right, so there's this whole phase here where you're manoeuvring the stretcher, and you can all attest to this, you've done this, right? So you're manoeuvring the stretcher inboard the aircraft. And there's a long period where you're essentially hands-off, you're not ventilating the patient. So the patient's not getting ventilated. So with that in mind, we do lots of training, and this is some training we were doing out at Menangle, down that way, of what it would look like to bring a patient down from a rock, a vertical job. So from a rock wall, potentially with a harness hang syndrome or some other form of ailment or injury that's caused them to need rescuing. And then it's just preparation is essentially the key. And here you've got a team, what it looks like once the patient's then popped into the litter and then they're about to go through and perform the RSI. Sometimes we do these things at night, and there's an operational job where we intubated the patient down on a rock shelf and then again winched them out. The physician stating that it was a challenging case because they'd seen this at coffee and cases, they'd heard about this, they'd even mentally rehearsed this. But for actually having done that physical skill and really put that thought process to the test, it hadn't been done. And so they found it really challenging, and there were long periods where the patient wasn't ventilated before. And this is a recurrent theme. It's not indicative of this one clinician. It's indicative of a process that has a fault inherently in it. That was just a sexy photo. Okay, so essentially, I mentioned that we did run a sim. So we ran this sim 3 years ago. What we were looking at was the ability for someone on the winch trainer with no environmentals running to detect a disconnection, right? And so when we did that, we put 21 doctors and we got them to connect up on the hook and then look at how they would manage a ventilator and potentially a drop in CO2 or an alarm indication whilst on the hook. They weren't told about what the sim was about, unlike you guys today, you're getting full disclosure and you know all about it. And they weren't told at all why they were there. So they're just running through what their normal drills would be. 14 of them were given a ventilator to use. One that they were familiar with, right? But the process, we'd not trained, we'd not talked, we'd never briefed. So this was them completely rolling with the punches, so to speak, and scanning off piece, which is not something we condone. But it was to gauge an idea of how well we, as a group, can manage these patients. So 14 were given the Medumat, and 7 were given just a handbag, standard practice, standard care. Now, out of those, 2 didn't detect a disconnect, right? So that's the handbagging group. Out of this group, I'm visualist, in case you didn't gather, so I had to figure out how to do this in a way that would make sense to me. So we get 5.
Why are you not burping a lot?
Yeah, it's a big morning.
No one hasn't been here for a while.
So, there's an Coke out there.
Yeah. So there were 5 from the Medumat group that didn't detect a disconnect. There were 2 unicorns, 1 from each group, and they did detect a disconnect, but they did it when they were on the ground. Okay? So essentially, what the purpose of showing you this was that we had a group of 21 clinicians. We were able to identify a lot of disconnects, but out of both groups, this number's too large. Right? There's a large number of patients, 7 out of 21, where we didn't either detect a fall of CO2 to 0, which we were able to accurately produce during the sim, or we didn't detect an alarm. The 2 unicorns did detect the alarm and detected it as weight was coming on the hook, or even before the hook was delivered. So they elected to give the emergency signal, and one gave the abort signal, and they resolved the problem on the ground and then continued the evolution. Make sense? So with that in mind, we look at this cyclic. We're delivering a chat about a pre-Spectre departure checklist for intubated patients. And so there's a couple of things here I want to run through that you're going to go through again in cyclic, but for those of you that don't get there, this is a nice way to touch off on it. So we want to ensure that you're going.
Have we got an idea of how underventilated the hand ventilated patients are?
Look, that's a good question, Chris. The paper that everyone refers to is the Hollett paper, which looked at the variance of clinicians delivering both rate and volume, and compared to a ventilator, it was chalk and cheese. That's a 2017 paper. Look, and I can't remember the numbers off the top of my head, but essentially of the 10 clinicians, I think there was one, again, a unicorn there, Pierce, who, if you've ever seen I encourage you to look up the graphical images of the ventilations. One looks like a ventilator, but I'll let you guess who that might have been. But everyone else, essentially, the rate and depth, rate and volume that was delivered was considerably inferior to a ventilator. And typically these patients are intubated because they have a clinical need. That's why we're electing to do it in that remote and austere environment, right? So with that in mind, a pre-departure checklist for our intubated patients. So the airway is secured, the depth is shared with the team, we've got our connections and they're all push twisted. So we want to see that today when you're doing the sim. Breathing, we've got no visible alarms on the ventilator. And what colour does the Medumat alarms go when we want to do something about it? Anyone? What colour?
What do you reckon a bad alarm?
A bad alarm. Anyone? Thank you. Oh goodness, this is going to be a bad day. Right. We're going to claw this back. Awesome. So there are no alarms. There is an orange indication alarm. There's no green alarms, people, right? So the orange alarm.
Everything's okay.
It's all okay unless it's red. Right. Good. So red alarm means bad. Means do something about it. Okay. So we've got no visible alarms that are red. okay, when we start the procedure. We have sufficient oxygen. And so for our checklist, we're going to ensure that we've not in the red bar, take the theme here, the red section of the oxygen cylinder, because that's going to indicate that we have less than 200 litres of volume, okay, with the CD composite cylinders we use. The BVM is accessible and secured to the upright or the horizontal bar of the stretcher. Upright or the horizontal bar? Thank you, Chris. Anyone else? Upright? Upright. Awesome. Why? Because if it's on the horizontal bar and the downwash comes along, it may push it out of reach, so you can't reach it. So it needs to be on the upright. Yep. The EMA is secure, and I've got an old helmet to show you why it needs to be secured. And it's just girth hitched around the circuit. Yep. The SATS probe is secured, and again, girth hitched around just the patient's right hand if you can. We've got circulation, so the fluids are secured and the giving port is accessible. Probably one thing we should have put there is that the circuit from the Oxy Sock runs into the sleeping bag and up to the mouth, and that's just to reduce the amount of movement that you may get on the circuit itself. This has got a larger surface area. So into the sleeping bag, up to the connection at the ET tube, and everything's push twisted. Circulation, IV fluids are secured, and we've got that loaf stowed away. Drugs, you've got adequate drugs as the clinician going up with the patient, so that if we don't come up because of some reason, a chip light or an issue, you've got enough to continue the job and get the patient safely to hospital. And extra free drawings if required. Because remember, we've got the primary packs on the ground, so if you need more rock, that's the time to think about it, yeah? Equipment. So the Oxy Sock is secured via 2 points, the fluid loaf is secure in a way, and the airway extirpation plan has been verbalised. Here, I want you to think about what are you going to do with your actions on, and that'll come up in a minute when we look at the quick training video. Aircraft specific, we're going to give the brief to the crew so that they can have the back of the IAM prepared. But equally, if you're coming off out of a industrial site, where are you going to? Where's the stretcher? Where's the back of the ambulance set? How's it going to be set up? What's the receiving point? You know, this is where we want to be thinking about this stuff and having it forward planned. And attention to maintaining the diamond scan is all about what it is you're going to do when you're on the hook. So I'm going to start at my CCP, look up at the air crew officer, down at the tube and the EMA, and then back to the SATs if it's out. Yep, and we're just going to keep that scan. All right, there's a nice little video showing us that in a minute. Again, this was cyclic two years ago, where we tried to get this off the ground, pun intended, and that was really what held us up there. It was COVID, and essentially us being unable to rerun this sim and prove that this procedure is as safe as what we currently do.